To truly address the needs of this population with SAVA, we clinicians must consider the compound burden of these epidemics and deal with them in a comprehensive and culturally meaningful way. On a clinical basis, this implies using multidisciplinary approaches to effectively screen for substance abuse, depression or PTSD, and violence in the setting of HIV care. We know that screening for substance use and depression is effective in identifying affected patients and introducing support. In a study of almost 1,400 individuals, in the waiting room at each visit, HIV-positive patients completed PHQ-9 for depression, substance abuse and mental illness symptoms screener, and questions about adherence. A little over 12% had indications of moderate or severe depression, and this was associated with decreased adherence. 19% had indications of problematic drinking, and 8.2% had indications of problematic drug use. In a quote from this study, patients were willing to disclose mental health distress, substance use, and suboptimal medication adherence to providers, highlighting the importance of routinely assessing these behaviors during clinic visits. In a study from an HIV clinic in Alberta, Canada, of over 1,700 individuals, 46% of women in HIV care had experienced IPV. Only 22% of patients had been asked about violence in any other healthcare setting. Patients were responsive to routine violence screening, but referral services need to be easily accessible. 23% of patients in the study disclosing IPV were connected to resources after screening. The author stated, "We recommend that universal IPV screening be incorporated within regular HIV clinic care. The IPV survey should be given after trust has been established with regular follow-up every 6 to 12 months. A referral process to local agencies dealing with IPV must be in place for patients disclosing abuse." In a study from an HIV clinic in Chicago, including 102 women of color, they tested a novel approach to screening. At baseline, they administered a women's experience of battering scale, a 3-question ER screening for IPV, 1 question measuring fear of partner as a barrier to care, and they were asked to identify the level of safety they felt in their relationship, which was an acuity assessment. At 3 months, they were asked, quote, "How likely is it that you became infected with HIV as a result of being forced to have sex with someone who may have been infected," unquote. And they had a repeat acuity assessment every 6 months. The results of this study found that women reporting IPV were approximately 8 times less likely to be virally suppressed. 70.6% indicated a history of violence using the composite measure, which meant screening positive on at least 1 screening tool. 35% identified a history of sexual assault. The acuity assessment identified 41% of participants as having a history of IPV. And the baseline ER screening questions identified 37% of participants as having a history of IPV. The author stated that asking questions multiple times in a variety of ways may be key to identifying women who may not disclose violence when first asked. There are a number of possible clues to IPV that clinicians should be aware of. Evidence of physical trauma, including bruising, abrasions, especially if these are repeated over time with vague or implausible explanations. Unexplained chronic GI or genitourinary symptoms, such as chronic pain or frequent urinary tract infections. Unexplained reproductive tract symptoms, chronic pelvic pain, sexual dysfunction, repeated sexually transmitted infections, or unexplained genital or anal injury. multiple unintended pregnancies and/or pregnancy terminations, other unexplained chronic pain, repeated health consultations with no clear diagnosis, an intrusive partner who insists on being present during consultations, symptoms of depression, anxiety, PTSD, or sleep disorders, and suicidal ideation and/or behaviors or other self-harm. There are also several emotional indicators that may indicate abuse. A patient who shows discomfort when discussing the possibility of abuse, or who seems fearful of a partner. A patient who appears to be embarrassed, ashamed, frightened, disoriented, or depressed. Excessive distress over a minor injury or little emotion over a serious injury. A patient who is unusually quiet or jumpy or nervous. One who has a limited attention span during assessment. Or hypervigilance among a victim or an abusive partner. There are several validated IPV screening tools. This slide lists 4, along with their sensitivity, specificity, positive and negative predictive values, as well as pros and cons. The abuse assessment screen, which will be demonstrated on the next slide, has 4 questions. It assesses sexual violence. It assesses non-fatal strangulation. It was developed for and tested in pregnant women, and these are all pros. There has been some inconsistent psychometrics in studies looking at this tool. It is nevertheless a commonly used tool and may be a feature of various electronic medical records. These are the questions, including, have you ever been physically or emotionally abused by your partner or someone important to you? Within the last year, have you been pushed, shoved, slapped, hit, kicked, choked, or otherwise physically hurt by your partner or ex-partner? And for pregnant women, since you've been pregnant, have you been hit, slapped, kicked, or otherwise physically hurt by someone? Within the last year, has anyone forced you to have sexual activities that you did not want? And finally, are you afraid of anyone? The U.S. Preventive Services Task Force recommends screening in adolescents and adults in clinical practices that have systems in place to ensure accurate diagnosis, effective treatment, and follow-up for depression. One of the most common screens is the PHQ-2 and PHQ-9. The PHQ-2 has a 97% sensitivity and 67% specificity in adults. The PHQ-9 has a 61% sensitivity and 94% specificity in adults. In general, the PHQ-2 is assessed first, and if it is positive, the PHQ-9 should then be administered. The PHQ-2 asks, over the last 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure in doing things, feeling down, depressed, or hopeless. And with the scoring as noted, score of 0 means not at all, score of 1 means several days the patient has been bothered by these problems. Score of 2, more than half the days in the last 2 weeks, and 3, nearly every day. A score greater than 0 in general should default or be followed by the PHQ-9. And this is the PHQ-9 with the same scoring system. Over the last 2 weeks, how often have you been bothered by the following problems? Little interest or pleasure in doing things, feeling down, depressed, or hopeless, trouble falling asleep, staying asleep, or sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself or that you're a failure or have let yourself or your family down, trouble concentrating on things such as reading the newspaper or watching TV, moving or speaking so slowly that other people could have noticed, or the opposite, being so fidgety or restless that you've been moving around a lot more than usual. And finally, thoughts that you would be better off dead or of hurting yourself in some way. The SBIRT is a screening system to identify substance use or abuse. It stands for screening, brief intervention, and referral to treatment. The screening implies application of a simple test to determine if a patient is at risk for or may have an alcohol or substance use disorder. Brief intervention is the explanation of screening results, information on safe use, assessment of readiness to change, and advice on change. And referral to treatment involves referring patients with positive results on screening for a more in-depth assessment and/or treatment. This slide demonstrates two single triage questions for drug or alcohol use that may be of use. The first is, how many times in the past year have you used an illegal drug or used prescription medication for non-medical reasons? Similarly, how many times in the past year have you had X or more standard drinks in a day, where X is 5 for men and 4 for women? If someone screens positive on the single questions, meaning 1 or more times in the past year, then there is a move to a validated tool. The link at the bottom of this slide represents a link to a variety of validated tools that may be used for substance use, including alcohol use. And in case you wondered, these are definitions of what a standard drink entails. 12 fluid ounces of a regular beer, 8 to 9 fluid ounces of malt liquor, 5 fluid ounces of table wine, or a 1.5 fluid ounce shot of 80 proof spirits. This is an example of a validated alcohol screen, Audit C, which questions how often did you have a drink containing alcohol in the past year? How many drinks did you have on a typical day in the past year when you were drinking? How often did you have 6 or more drinks on one occasion in the past year, with a scoring system? The rationale for using SBIRT, screening, brief intervention, and referral to treatment, is aimed to identify persons with substance use disorders, identify persons who are at high risk for developing a substance use disorder, to help patients reduce or eliminate alcohol or other drug consumption and therefore minimize or avoid associated problems, and to motivate patients to accept referrals for more specialized assessment and treatment services. There are a lot of data concerning the results of using this triage system. Using the Cochrane methodology, 69 primary care brief intervention trials for over 33,000 participants found that SBIRT significantly reduced alcohol consumption compared to controls. In a cross-site evaluation of SBIRT demonstration projects, 11 programs that were funded over 5 years to promote the adoption and sustained implementation of SBIRT were examined. Pre- and post differences were clinically meaningful and statistically significant for almost every measure of substance use. Greater intervention intensity was associated with larger decreases in substance use, and brief intervention was more cost-effective for most substances. SBIRT was associated with reduced healthcare costs, ED visits, and hospitalizations. How often should we screen for these conditions? For IPV, the U.S. Public Health Service Task Force recommends that clinicians screen women of childbearing age, but there was no evidence on appropriate intervals for screening. The American College of Obstetricians and Gynecologists provides guidance that all women should be screened at, quote, periodic intervals, including during obstetric care, at the first visit, and at least once per trimester, and at the postpartum visit. For depression and substance abuse, there are no formal evidence-based screening guidelines. Screening all postpartum women for depression is recommended by the U.S. Public Health Service Task Force, the American Academy of Family Practice, the American Academy of Pediatrics, and ACOG. The American Academy of Family Practice recommends that pregnant women should be screened at least once during the perinatal period for depression. Quote, consider screening at least once during pregnancy and again 4 to 8 weeks after delivery, unquote. Screening every patient at every visit for both depression and substance abuse may help identify more patients in need. There are barriers to IPV screening that have been identified by providers. As we have noted previously, there may be a lack of awareness of the problem or how prevalent it is. Many providers are uncomfortable with the topic. There may be in certain situations a tendency to blame the victim. Often providers complain of lack of training in this area. They may have inadequate resources or lack of knowledge of how to access available resources. They may be uncomfortable or not know how to respond to a positive screen. Lack of time is a pervasive problem identified by providers. Lack of privacy to screen, fear of offending patients, or the perception that screening is not the clinician's role. There are some significant considerations in screening. Screening should occur in a private area. The patient should be assured of confidentiality. Brochures or other materials in waiting rooms and bathrooms can be very helpful in helping patients disclose some of these problems or know about resources that are available. There should be a systematic protocol and a screening script. As we have mentioned, the use of validated screening tools, and providers should be aware of mandatory reporting issues and should disclose these to their patients or clients. And finally, as noted before in some of the studies, there needs to be a recognition of the need for referral resources when problems are identified. In terms of reporting IPV, do not contact the police without the adult victim's consent. Contacting the police without their consent may place the patient in a higher level of danger. Inform patients that they can contact the local police or state attorney general's office to request that charges be filed against the abuser. Victims may also file for a protective order. Please refer to specific state laws regarding confidentiality and reporting requirements. When there is a positive screen, first of all, acknowledge that there is an issue, a problem. Ask the woman if she wants help. Offer support and referrals. Encourage safety planning if IPV is identified. And provide additional assessments to determine the level of danger or suicidal ideation as appropriate. It's also important to identify relevant comorbidities that may need to be addressed. This slide graphically demonstrates some of the needs in terms of care. There are syndemic expert models where there is inclusion of assessment of HIV risk and referral for those who test positive. There is screening and referral for IPV. screening and referral for trauma or PTSD, and screening or referral for substance abuse disorders. The goal in secondary and tertiary syndemic interventions is first of all to provide integrated care for these problems, for prevention as well as for ongoing management. The ultimate goal is, of course, to decrease the prevalence and incidence of violence, substance use disorders, of trauma and PTSD symptoms, and to improve HIV care and decrease HIV risk for those who are HIV negative. This will involve community mobilization and prevention, and ultimately needs legislation, policy, and structural interventions to decriminalize drug use and redress issues related to violence. General considerations in terms of services and interventions include ensuring that services are culturally relevant and trauma-informed, incorporate gender-responsive, coordinated, collaborative, and integrated services, use peer supports, understand specific factors that influence access to and adherence to care, remembering the need for privacy and confidentiality, considerations concerning HIV disclosure, and the need to establish referral pathways. We know that treating depression can improve viral suppression. A retrospective chart review found that patients referred to on-location therapy services for depression had significant decreases in depression scores and decreases in HIV RNA levels associated with increases in CD4 cell count. Viral suppression and CD4 count increased, and PHQ-9 screening for depression improved after initiating antidepressants in a study that compared effectiveness of single versus dual-action antidepressants. No difference significantly was observed in the effectiveness of single versus dual-action medications in this study. Treating substance use is critically important. At a San Francisco methadone clinic, records of 65 HIV-infected patients were reviewed for retention and care and viral suppression. Women were more likely to attain suppression in the study, 96% versus 71% in men. Viral suppression was 14% higher for those who received HIV care on-site at the methadone clinic versus at an HIV clinic nearby, and was 31% higher compared to those who received care in community clinics. In a study from France, there was 2 to 3-fold better adherence to ART among those who had stopped injecting drugs while prescribed methadone or buprenorphine. The duration of opioid agonist therapy significantly was associated with increased rates of viral suppression. A study from Canada found that methadone treatment was associated with improved adherence, viral suppression, and CD4 count. Brief behavioral interventions can reduce syndemic risk for IPV and HIV among women who use drugs. Meta-analytic reviews and recent studies suggest that trauma-focused interventions that address substance abuse disorders, IPV, PTSD associated with IPV-related trauma, and HIV/AIDS in an integrated, concurrent approach are more likely to succeed and are more likely to be cost-effective, as well as to increase medication adherence and to reduce symptoms of PTSD. Other trauma-informed interventions for those who are HIV positive have revealed significant effects in reducing substance use, decreasing PTSD symptoms, decreasing unprotected sex, as well as improving medication adherence. Thank you for listening. You've been listening to Optimizing Disease Management, Finding the Invisible Patient. This is Dr. Jean Anderson.